On Monday, the 20th of October, 2025, we're talking to Dr. Augusta, or Professor Augusta Eneh and Dr. Jallow, consultant neonatologist and pediatric surgeon, respectively. So, how do your two specialties intersect? And can you cite a case where neonatal care and, pediatric surgery had to work hand in hand?
Yeah, they intercept very much. We work hand in hand. Dr. Jallow, we always calling him to come and see a patient because newborns also have, like I said, surgical problems. And those surgical problems are being managed by the pediatric surgeon. Some of them, he has mentioned, it can be intestinal obstruction. It can be maybe tracheoesophageal fistula. That's the food pipe
not connected.
Not connected. Maybe it's connected to the air pipe. So you can imagine if the baby is fed, goes into the lungs, and it has to be intervened immediately. Needs urgent, and Dr. Jallow is always ready to intervene. Once we call him, he comes around. And after he's operating, he sends the babies back to us. And we take care of the baby. So we are always working together, hand in hand.
Can you cite a particular case?
Many.
Or there are so many
there are plenty. Just not long ago, in fact, we have one of the first survivors of what we call gastroschisis. Almost all of you have been having 100%. But the first one went home, I think this week. We were very excited. That is when a baby is born, all the intestines are outside. And then you get so scared. So that one, we put a nylon around it, then we pushed all the intestine in within 3 days. Then when it goes in, then you cover it. So they manage to make sure the temperature is okay, there is no infection, and then the fluid, all those things are fine. But the problem with those babies, they could have infections, and then they could be so dehydrated, and we've been losing them. And then by 5 days, when everything is in, sometimes you lose. But thank God, they really supported in that. And even the esophageal atresia, when the food pipe is not connected, you realize then because it's not connected, all the secretion goes to the lungs. Then they help manage that with us. And then after surgery also, then they continue. So you will realize without us, they cannot go. And without them, we cannot go. We'll find it very difficult. But without us too, they cannot go because we are the one who will be able to support those patients for us. So it's a teamwork, it's a partnership, which we really treasure very much. And then our work, I can tell you, have been very amicable. While our teams are all growing, we are setting very strong teams for posterity in the teaching hospital. And then the work between us had been very harmonious. Yeah.
And what advice, Dr. Eneh, would you give to parents about early signs in issues about infants and young children, health issues?
Okay. Babies, children are actually vulnerable because everything about them depends on the baby. Decisions the baby take, the parents take, has impact, both either positive or negative, on the baby. Even from during pregnancy, the baby in the womb depends completely on the mother for nutrition, for everything. Then after birth, it still depends on the mother for breast milk and all that. And every decision, especially health decision that they take, impacts positively or negatively. Delay is the greatest problem we have, or ignorance, even identifying that there's a problem, because the babies don't talk, the children don't talk. So it depends on the parents' perception, the mother's perception, and most of the time, they ignore these babies when they have like fever, not sucking, literally they just ignore and wait till maybe it's full blown, the baby is convulsing. So early, first of all, identification that this baby is ill. There are some danger signs that they should know. Something like fever is danger sign. One, breathing, difficulty in breathing is danger sign. Not sucking, inability to suck well, is a danger sign. Then, if the baby is convulsing, it's another danger sign. So having maybe diarrhea, watery stool, they may think because an adult may have it and, go along. But for the baby, it's very, very urgent. They need urgent treatment. So identifying the danger sign, then taking decision, because some of them we have come across, they identify those things. Like this jaundice, some mothers, they notice the yellowness of the skin, but they didn't come to hospital because they didn't take it seriously. Even when some of them were even alerted that you should go to the hospital, they may wait 2 or 3 days until the baby is unable to suck. By then, the brain has been damaged. So, identifying the danger sign, taking decision immediately to come to the hospital. These are very, very important for the newborn care. Like I said, newborns, children are vulnerable because they depend on this. So, if a parent takes a wrong decision, decide not to go to hospital, it's going to affect the baby.
Sure.
Yeah, but if he takes the right decision and acts, it will also affect the baby positively. So those are some of the things I think the parents should be aware. Taking the right decision, acting immediately. Danger signs, very simple things. When they have fever, when they are not breathing very well, when they are not eating well, especially sucking for the newborn, when they are not sucking, and when they see some signs like convulsion, it's subtle in babies. So they should come to the hospital immediately.
All right. And taking, the responsibility away now from the parents, Dr. Jallow, how can communities better support child health, especially in the rural areas? Where you don't have EFSTH.
Yes. So now, so for us, EFSTH is being very supportive to other hospitals, because in fact, when we train, we're supposed to send so that we support. Currently, like we've taken over Birkama's maternity services. We just had neonatal audit on Friday, and then we able to tease out where the referrals are coming from, and then we working on supporting, and then our residency trainings, they all own regions where they go to. Pediatric surgery, we always go with AMISurg, that's the Gambians charity group. We always go every 3 months up country with them. We operate any babies in their own localities, and then even next in November we will be in Bansang to operate kids. So the people who have been trained from our path, the 3 people, and then after the objective is to support the hinterland. So those are some of the things, but the teaching hospital is poised in supporting other facilities, and then that is known from medication. Some of the strategies we have put in place, getting free drugs, we pay for the transport from MAPS, from Pfizer and other places. We share some of these very vital medications with other hospitals for free of charge, which would have costed them millions of dollars. And then we know as a teaching hospital, we can't do it alone. If the periphery is taken care of, our work will be less. We will be able to concentrate on our postgraduate training, on doing super specialty activities, and then also on doing research, and then implementing some of those findings. So that's a conscious effort we are doing as a teaching hospital.
Okay. What policies or investments would you like to see to strengthen neonatal and pediatric surgical care? Let's start with Professor Eneh here.
Okay. He will talk about the surgical care. I will talk about the
neonatal
medical care. Yes. Yeah. The first thing I would like to see a policy is to have to open neonatal units in some rural areas, equip them, and then train manpower. I have said that nursing care, neonatal care, is a lot of nursing care. But these nurses had to be trained in neonatal care. Then, for the doctors, thank God, we have postgraduate training. We have trained some of our doctors. They are now senior registrars. Recently, we had about 8 of them new. We had some before. So training in neonatal care, apart from training as being a doctor, a pediatrician, it still needs another specialized training to become a neonatologist. So the government should look into that to train some of these senior registrars eventually to become neonatologists, so that they can go to these areas where they have set up newborn care, so that some babies can be managed in the rural area instead of sending all to EFSCH. Then another policy is, I think, the policy of the referral. A lot of the hospitals or the health centers refer from one hospital to another health care before they eventually, so the delay is so much. I think there's a policy like that. They cannot refer directly.
They can't?
Yes. So they refer, and those hospitals, health facilities they refer, cannot take care of these babies. So by the time they get there, nothing much is done. They are waiting for ambulance to send them to another health facility where they can still not manage this baby. So by the time they go round and round and eventually come to us, the delay, damage has been done. So that policy should be looked into. There are some critical ill babies that can be referred, not all, that should be referred directly to gain time, because especially for this asphyxia I've talked about, perinatal that damages the brain, the first 6 hours is very critical.
Oh, wow.
Whatever we do, so that is the time you can actually intervene and help. But by the time they go round and round, it has taken more than 24 hours, 72 hours for them to come to us. So they should look into that referral. Then another policy is policy on training skilled birth attendants for every delivery. It's huge, it's a lot, but it's very important if we really have to reduce neonatal mortality. Skilled birth attendants. And when I mean skilled birth, not just training, you train them, then you go and make sure that what they are trained is being implemented. Because a lot of trainings go on, but implementation is the problem. Are they being implemented, those training? And then changing the nurses. Some nurses have been trained in this thing, but after some time, you take them to surgery, you take them to other where they are not really needed. So it's to look at that policy for those who have been trained for specific things should remain there, so that they impact the system. Then equipment, very important. Equipment is very important. In EFSCH, we have a NICU where that's the old NICU where we are staying right now. The capacity built was maybe for 40 babies, but at times we have 80 babies. So the place is small. The equipment we have, at times we put 2 babies in an incubator, which should not be, but because we cannot send babies back, it's the last bus stop, final bus stop. So when they come, we admit them. And when we admit them, the equipment we have, they are constantly in use. So they break down very often. We need more equipment. They should look at it, providing equipment. The hospital is actually trying, the ministry is trying, but we need to do more. Absolutely. But we have a new NICU provided by the World Bank. I guess maybe by December, and the government, yes. Maybe by December, it should be handed over. And we're looking forward to that. But in spite of that, it may not even be enough, because there's awareness now. They are sending a lot of babies to us. Like I said, in a month, you might have 80 babies. When I mean babies, ill babies. So the staffing, we need more nurses, trained nurses, more trained doctors that are interested in newborn care. It's very, very important.
The policymakers are listening to this program. Dr. Jallow, what investments or policies for you would you like to see to strengthen, pediatric surgery?
She spoke about some of the policies, referral policies, and all of that really affect us. I would want to see those things on board. Some of the investment areas I would want to see in pediatric surgery would be, like I said, to have a dedicated child-friendly theater. The space is there, and then there are people who are ready to furnish, but cement and block is they don't do. Another place of investment is having equipment like cystoscope, because we are pediatric urologists. Pediatric urologists handle, when you say urology, usually it's adult urology. So when you're talking about pediatric urology, you have to put pediatrics, because you handle all the urology problems in children. So we have it. We some of the babies have problem with inside their bladder, around that area. So you need a scope. We call it cystoscope. And the one we have it has been provided. We are very grateful, but it's getting out of use. And then also a pediatric endoscope. So you realize these ones are very much working in adults, but usually kids are forgotten. That's just the dilemma. That's why you imagine we had plenty general surgeons, but it has to take the country over 50 years to have a pediatric surgeon. The country could have invested, but thank God our government was able to do. And then now with the strategies in place, we will continue to provide more, because some of my colleagues are coming out. And then the other investment we would want to see in pediatric surgery is training, to train our nurses as critical care nurses to take care of our recovery room, our ICUs, and our theaters, and then to train more anesthetists. To be able, because theaters are expanding. Not long ago, a urology theater is opened. When you say urology, that's adult urology is opened, and then that theater needs staff and all of that. So now, when we also opened, we need that, and then you'll be talking about Farato, which would also really support. Take healthcare level in this country to another level.
The future looks bright.
So,
all right, you can't fit everything, unfortunately, into the program this morning.
Yes.
We cannot end without talking about what's about to take place at the FSTH this morning. I'm sure from here you are rushing straight.
Yes, exactly.
Onto that.
I'm grateful you are giving us the platform for that. I think it's in national spirit, because some of these things are known denominating, and then they are non-political, and then they impact the life of the people who really needs it, the ones who can't afford to even move from one area of our country to another. And then this morning, a fully piped hospital will be handed over to us. That's Edward Francis Multi-Gen Hospital. The hospital is fully piped with oxygen, and then with a state-of-art machine. If we say state-of-art, top-notch, it's not political. It's we have been very honest on it, and then it costed the donors from government to other international donors, like direct relief, and then millions of dollars, and then it took about 2 years for us to have it. UNDP plans are also coming on, so this activity is making us self-sufficient in providing air, oxygen for our patients, without which our mortality will really skyrocket, especially the neonate. And we are doing that at 10 a.m. this morning. And we want to tell Gambians that this activity is taking place, and the Tejan Hospital have gotten this improvement courtesy to all the goodwill people, including our government and other Gambians who are very passionate about seeing Gambia in the forefront. So we are doing that this morning.
Fantastic.
Yeah.
And just on the significance, some few words on the significance of, having the entire hospital piped for oxygen supply, and not just that, but also having the hospital having its own oxygen plant or plants.
Yes,
yeah,
exactly.
It's very significant for us in the newborn. The newborn, they need a lot of oxygen. And when it's piped, it makes it easy for them, because especially the premature babies, their lungs are not matured. So when they are born, they are dependent. So we keep on giving them oxygen. Like he said before, now carrying the cylinders, going to buy is not available when you need it.
Exactly.
Yes, but now I'm happy, very happy.
Fantastic.
That's it. Yes,
it's good to see you happy.
Yeah,
when you are happy, There's a fighting chance for our newborns.
Yes, but another thing, just to add, don't worry, we need CPAP.
What's CPAP?
It's a machine that helps to keep these babies, to help them in breathing, preterm babies.
Okay.
The machine.
What we call premature here.
Yes, premature babies. So it's very, and we need firefly phototherapy.
More fireflies.
More, because the numbers are
we can't
many.
give you everything.
Yeah, I know, but these ones are the basic things that I know that people can give us.
As I said, the policymakers are listening.
Yes. Okay.
Dr. Eneh, Dr. Jallow, thank you so very much for coming this morning, and we'd like to thank Comium for their partnership. Dr. Jallow, what again?
Yes, so I think it would not be fair if I don't recognize the efforts of the people who allowed some of us to be here. They sacrificed a lot of things. That's my own wife and kids. Without them, I will not stay in this country.
You're coming to this program only to thank your wife and your children.
And then also
if everybody who comes on the program does that.
Yes. So, but imagine you are working 24/7. It means you are doing it at the backdrop of people.
Being the spouse of a doctor is not easy.
And then probably some families and other things, and then colleagues, and then also like Prof. Eneh. I think this country owe all these people a lot.
With Doctors Augusta Eneh and Cherno Jallow, we explored the world of neonatology and pediatric surgery as part of a broader look at health in the Gambia.
Jar Oil. The company have filling stations across the country, and our rates are relatively cheaper than anyone else across the country. Jar Oil is the biggest producer and distributor of cement in the country with the most competitive prices in the market.
Axel jam si Wave.
Yo, Abla, yo lu tax doo dee dégg lu tax mënuloo jël moto nga andil ma xaalis. Hello? Xana lay waxaat.
Bësal mu fay.
What?
Bësal mu fine.
Yes!
Wave Axina Gambia. Deposit and withdraw money, pay bills and buy mobile credit without fees. Transfer money wherever in the country for only 1% fee. Ak Wave. Bësal mu fine. Wave. Your money is yours.